Good afternoon, everyone. Thank you for joining me. It is my distinct pleasure to introduce a longtime and esteemed colleague, Dr. Branson. Dr. Branson is the Associate Director for Laboratory Diagnostics for HIV at the Centers for Disease Control, and he has been one of the chief architects of CDC's activities around HIV testing, including evaluating new technologies, rapid testing strategies, and incidence testing. He was the lead author on CDC's revised recommendations for HIV testing of adults, adolescents, and pregnant women in healthcare settings. And he's worked very closely with the CLSI and the Association of Public Health Laboratories on the development of laboratory guidelines for establishing the diagnosis of HIV infection. Dr. Branson has been involved with HIV testing for more than 25 years and working in the HIV field since the early 80s. He has over 50 peer-reviewed articles and his name to his name on HIV diagnostics and screening. And before joining the Centers for Disease Control, Dr. Branson was in private practice and on the clinical faculty of Johns Hopkins. Dr. Branson, I'll turn it over to you now.
Great. Thank you, Lisa. Are you able to hear me?
Yes, we hear you. Thank you.
Great. I am going to need to share my desktop in order to be able to show the PowerPoint presentation for today. And I appreciate all the people who have joined us on this webinar to talk about updates on HIV testing. The thing I plan to talk about today is, first of all, changes in HIV testing technology, detecting acute HIV infection, a little tiny bit about HIV-2, talk about the new HIV diagnostic testing algorithm, which has an emphasis on sensitivity, and then talk a little bit about follow-up testing and present the results of sort of an old trial of the multiple rapid test algorithm, because that tends to be something that comes up a lot in people's minds. First of all, in terms of the evolution of HIV tests, in general, tests are grouped into generations. First generation tests were, of course, the original EIA. They're based on a ground-up whole virus or a whole viral lysate that's grown in cell culture. But the big characteristic of both first-generation tests and second-generation tests is that they detect only IgG antibodies. And the IgG antibodies, of course, are the second antibodies to appear. IgM antibodies are the first antibodies to develop after infection, and those are detected by third-generation tests, which pick up both IgM and IgG antibodies. And then the most recently developed tests were the fourth-generation tests, which detect P24 antigen as well as IgM and IgG antibodies. Just a little bit of terminology. COM-B tests, according to the FDA, are the ones that are designed to detect both HIV-1 and HIV-2 antibodies. COMBO tests are the fourth-generation tests that detect both antigen and antibody. And then NAT tests, or nucleic acid tests, detect either HIV RNA or HIV DNA. Looking at sort of a graph of exactly what happens after the time of HIV infection, on this model, HIV infection happens at point 0. The first thing to appear is HIV RNA, which shows up between 10 and 12 days or so after the time of infection. Subsequently, P24 antigen appears about 5 days after RNA, approximately 15 days after the time of infection. But as antibody begins to appear, it binds to the P24 antigen, and P24 antigen disappears. Antibodies, IgM antibodies in particular, show up around 21 or 22 days after infection, and then IgG antibodies begin to show up at around 40 days or 6 weeks after the time of infection. And so in terms of the evolution of the test and where these things all fit together, the IgM antibodies are the ones that show up first, IgG antibodies show up second, and what we've been using up until now are all antibody tests. The first generation tests don't pick up infection till somewhere around maybe 50 days after infection. And it's important, I think, to point out that Western blot is a first generation test. The second generation tests pick up IgG antibodies a little bit sooner. Most of the rapid HIV tests are second generation tests that pick up IgG antibodies. The third generation tests, which are used in laboratory assays, pick up IgM antibodies at around 21 or 22 days. And then the fourth generation tests pick up infection earliest at about 15 days after infection, 5 days after RNA shows up. As I mentioned, the original EIA was the first generation test. The Western Blot and the IFA, which have long been the confirmatory tests, are also first generation tests. They only pick up IgG antibodies. They're based on proteins from the whole virus, and so they will detect infection later than most of the tests that are currently being used as the initial tests for HIV. The CLIA point-of-care rapid HIV tests, in particular the waved tests, the lateral flow tests, as well as the INSTI, the flow-through tests, all pick up infection, all detect IgG antibodies, and so they're second-generation classes of tests. Did want to mention there are a couple of new rapid tests. They also detect IgG antibodies, but in case you weren't aware, the DPP, which stands for Dual Path Platform, was approved by the FDA in December of 2012. The company is still applying for waiver, but it is currently a moderate complexity test for serum or for plasma, for whole blood, or for oral fluid. So it's the second oral fluid test that we have available. This is somewhat different than the other tests that we're used to. For the collection of oral fluid, it uses this sort of swab that you use on the upper and lower gums. But the swab then has a place where you break it off, and whether you use a whole blood specimen or an oral fluid specimen, you add it to the little vial called the sample tainer, which is used to apply it to the test device. But what that also means is that unlike the other tests, you do have specimen left after you run the test, so that most of the others where you apply the specimen directly and you would have to obtain a new finger stick or a new oral swab for a second test, with the DPP in this little container, you only use a few drops of it and you still have specimen in order to repeat the test if you need to. The dual path platform works somewhat differently than the other tests in that you put the specimen on in the first little well down at the bottom. It migrates upwards across the test strip, and then you put the buffer or the developer solution in the second well after those little blue lines disappear. I'm hoping you can see them on the slide. And it migrates across the strip the same way as the lateral flow tests. This increases the sensitivity of the test, and it also allows you to do multiplexing or multiple different antigens. And the company is working on a combination test that would detect syphilis and HIV, or syphilis, HIV, and hepatitis B, which would work better because of this sort of two-direction migration, one for the specimen and one for the color reagent. This test is read like the other lateral flow rapid test, which is a stripe at the control location is negative. A stripe at both the control location and the test location would be a reactive test result for HIV. I think most of you have also heard that the Determine Combo Rapid Antigen Antibody Test has been approved by the FDA. It was approved in August of 2013. It is a CLIA moderate complexity test. It's designed for use with whole blood, for serum, or plasma. The company is conducting the trials and applying for CLIA waiver. And it is somewhat different in that it distinguishes antigen from antibody, so that when you look at the test strip, you would apply the specimen down at the area on the right where the little blue arrows are. It takes a 50 microliter or a full drop of blood or of serum, but then it has a separate location where a stripe would appear for antibody, a stripe would appear for P24 antigen, and then of course the control stripe. And so this would differentiate antigen from antibody. And I'll show you in a minute what our experiments have shown so far in terms of how it compares to the other rapid and laboratory tests. I do want to mention that especially for healthcare settings, we do have the ability to do rapid HIV test results without rapid HIV test kits, and those are these random access multi-platform analyzers that are in particular in use in a lot of hospitals where they allow onboard refrigeration for multiple different assays. The random access, because you can push the button and tell it to do HIV or hepatitis B or an HCG kind of test. You can get a stat sample request, and most of these would give you a test result in less than 60 minutes without pausing for the rest of the tests. This one was the first to be approved, the Advia Centaur. It's a third generation format antibody test. At the current time, it's a chemiluminescent assay, so we don't call things EIAs anymore. The chemiluminescence is a slightly different sort of mechanism for detecting antibody. And the company Siemens, who makes the Advia Centaur, is also submitting their fourth generation test for FDA approval, so that soon we'll have another 4th-generation antigen-antibody combination alternative. The orthovitros is another 3rd-generation chemiluminescent assay. Again, it generates a test result in less than 1 hour. It is so far just an antibody test. This one was approved in March 2008. And then the Abbott Architect, approved in June 2010, is a 4th-generation chemiluminescent assay that picks up both P24 antigen and HIV antibody, although it doesn't distinguish between them. So when you get a positive test result, you don't know whether it's antigen or antibody that's positive, and it will generate a test result in about half an hour from the time that you add the first specimen. This is not a multi-platform analyzer, but the other currently FDA-approved 4th-generation assay is the Bio-Rad HIV combo antigen antibody EIA, and it is an EIA. It works the same as a multi-well plate like the other EIAs. It was FDA-approved in July of 2011. The issue with all these tests currently available, the rapid tests, as well as the laboratory tests, I think many of you have seen this before. CDC conducted an analysis of plasma seroconversion panels. There were 26 seroconverters who were analyzed with multiple different specimens, about 137 specimens. They were tested with all the FDA-approved assays. And in order to compare how soon they picked up infection, we basically looked at when each of these tests detected 50% of the specimens from each of the seroconversion panels. And so what I'm going to show you is something called 50% cumulative frequency. And I make that point because this is not exactly the same thing as a window period. In seroconversion panels, people are not all bled at exactly the same intervals, and of course they're not bled every day, and so there's somewhat of a range between the number of days these tests turn positive. But by showing a comparison, we don't know when people got infected, but we do know when the Western blot turned positive, and so this looks at the relative appearance or the relative detection of each of the tests by the FDA-approved assays. The Viranostica was the assay that was in widespread use until 2007 when it was withdrawn from the market. And I show it here because, number one, it turns positive just after the Western blot, but also it was the comparison test when most of the other rapid HIV tests were approved. So that when rapid test claims to have a sensitivity of 99.8% to 100%, its comparison test was the Viranostica because that was the prevailing test available for use in clinical trials. The lateral flow tests, OraQuick, Unigold, and the 2 Clearview tests pick up infection between 1 and 5 days before the Western blot turns positive. The flow-through or laboratory rapid test, Multispot and Reveal, 6 or 7 days. And the Avioc test, which is the EIA that's approved for use with conventional testing of oral fluid specimens, is again about 6 days before the Western blot. The INSTI test, which is the most recently CLIA-waived test, picks up infection about 9 days before the Western blot. The DPP, not yet CLIA-waived, but recently FDA-approved, again about 8 days before the Western blot. And then in blue here you see the laboratory-based 3rd-generation assays, including the random access ones that I showed you, which pick up infection just about 2 weeks before the Western blot turns positive. Then the 4th-generation assays pick up an infection about 3 weeks before the Western blot turns positive, approximately 5 days after the Aptima, which is the FDA-approved RNA test, first detects infection. And then looking in the schema of things, the determined combo, the antigen-antibody test, picks up infection right around the time 3rd-generation antibody tests, 3rd-generation laboratory antibody tests pick up an infection. So as you can see, the determined combo picks up infection about 15 days before the Western blot turns positive, slightly sooner than the 3rd-generation assays, but not quite as early as the 4th-generation assays. And so the determined, although it is an antigen-antibody combination test, it is not quite as sensitive as the laboratory-based 4th-generation tests. Sorry, this ended up being in there twice. One of the important considerations here, though, as well, is recent studies looking at oral fluid with the Avioc indicate that it picks up infection at about 40 days after the Western blot turns positive. So that all of the rest of these comparisons for the relative detection of HIV are based on plasma specimens. And so the likely period of detection, if you're using whole blood, and in particular if you're using oral fluid, because there are lower antibody concentrations, are going to be longer than the intervals that were shown when we use the plasma seroconversion panels. And I think that makes a big difference in terms of when we think how often people might need to be retested. In terms of looking at the period of acute infection, we define acute HIV infection as the time between RNA's appearance, when a person becomes infectious, and the time that infection is detected. So that with the first generation tests, including the Western blot, we're talking about a period here basically of 7 or nearly 8 weeks between the time that a person is infectious and the time that the test picks up infection. The second generation tests, again including most of the rapid tests, the interval is somewhat shorter. The laboratory-based third generation tests, as well as the determined combo, have an interval of between 10 and 14 days of acute infection. That's when levels of RNA are very high until the time it can be picked up by the test. And of course, the fourth generation P24 antigen tests have the shortest interval. Will pick up between 60 and 80% of people who have RNA present before the development of antibody. The big question, of course, is why this all matters, and it matters in particular for high incidence populations. This study was done among frequently tested MSM in Seattle by Joanne Steckler, where they ran a variety of different tests on the same people. And also they did pooled RNA screening to find everyone who was infected. So out of 192 men who were infected with HIV, 23 or 12% of them were detected only by RNA. Subset of those, 16 were tested by the fourth generation antigen antibody assay, and 15 out of those 16 were picked up. So as you see, this fourth generation test picks up most of the infections in people who have RNA present before antibody develops. 169 or 88% of them were detected by the third generation Serum antibody immunoassay, and only 80% of the people with infection were detected by the oral fluid rapid test. And so there is a considerable difference in how many infections you'll pick up depending on which assay you end up using. This is another analysis that was done in San Francisco looking at 4 different antibody tests. These were done during 4 different periods of time, and so they weren't all done on the same people. But what you see, for example, is that the OraQuick oral fluid test picked up none of the people with acute infection. Its sensitivity for established HIV infection compared to an antibody test was about 95%. Overall, its sensitivity for everyone who is HIV infected, that's the far right-hand column, is about 87%. The OraQuick fingerstick test had better sensitivity for established HIV infection, around 99%, but obviously was unable to pick up acute HIV infection in antibody-negative people. There is a comparison in the third line of the Diagnostic EIA, which was 100% sensitive for established HIV, but only 92% sensitive when you take into account the people with acute HIV infection. And then the third generation genetic systems EIA picked up about 3 of what were called acute HIV infections that were not detected by the Diagnostic EIA, and 100% of the people with established HIV infection. But again, taking into account acute HIV infection, the third generation EIA was only 96% sensitive. In looking at one of the other pieces of information that Jenny McFarland provided for me, in Houston, in their emergency departments, they were testing with third generation laboratory assays in 2 hospitals, and there were 238 patients who were repeatedly reactive on their EIA and either negative or indeterminate on the Western blot, and they sent those specimens for NAT testing. And 26, or nearly 11% of them, were positive for acute HIV infection. And so this is really, I think, the important evidence that it's not only the fourth generation test that makes a difference with the Western blot, but third generation assays as well will detect people who have HIV infection with negative or indeterminate Western blot results. And so whether people are screening with the third generation or a fourth generation assay, if the Western blot is negative or indeterminate, additional testing has to be done to find those people with acute HIV infection. There are some policy implications of this as well, and Texas has shared with me this policy that has been developed that will go into effect in June of 2014, where they will require their programs to use blood-based specimens, either fingerstick or venipuncture. And for confirmatory testing, they will require that they collect a venipuncture specimen after a preliminary positive rapid result. And they will not accept oral fluid specimens simply because of the difference in the time of detection of acute infection. And after reactive immunoassays, all the indeterminate and non-reactive confirmatory tests are going to be referred to NAT testing in order to detect additional people with acute HIV infection. And I think that sort of takes us into what CDC will be recommending as the new diagnostic algorithm. The fourth generation antigen antibody assays in several different studies have been shown to pick up between 70 and 84% of individuals who are RNA positive but antibody negative even on third generation antibody tests. And as I mentioned earlier, the fourth generation tests pick up infection between 4 and 5 days after RNA first detects infection. An example of when this sort of comes into effect was published in the MMWR back in June for HIV Testing Day, where an emergency department in Phoenix was screening with a fourth generation test of all their patients who had blood drawn. In this screening program, only 15% of patients declined testing. They identified 37 new HIV infections, but importantly, 12 of those were people who had acute HIV infection. So they were picked up by the fourth generation test, and they were negative on either the Western blot test or the multi-spot test. And when we looked at those 12 people, those with acute HIV infection had a median viral load of 3.6 million copies, compared to the people with established HIV infection whose viral load was only about 27,000 copies. So obviously those people with acute infection were considerably more infectious than the people with established HIV infection. And part of the reason potentially that the percentage was so high in this emergency department is that acute infection causes symptoms, and people seek treatment for symptoms, and so potentially they had symptoms of a viral illness for which they went to the emergency department. If they hadn't been doing this HIV screening, the HIV infection probably would have gone undetected. So we've talked about the limitations of antibody testing in that they don't detect infection in about 10% of infected persons who are at the highest risk of transmission because of the high viral loads. The Western blot confirmation is less sensitive during early infection than most of our widely used screening tests. And the antigen antibody combination tests that are now FDA approved will make this even worse in detecting infection in antibody negative persons during the highly infectious acute stage. Just a word about HIV-2. HIV-2, as far as we know, it still remains uncommon in the United States, but it does not respond to first-line therapy, to the non-nucleoside reverse transcriptase inhibitors, and to some of the protease inhibitors, and it's also undetectable by HIV-1 viral load tests. Viral load tests only pick up HIV-1 infection. What we didn't realize earlier until we studied this a little further is that HIV-2 tends to be misclassified by the HIV Western blot, so that in New York City, where they looked at their patients who turned out to have HIV-2, 93% of the patients who had a Western blot done had an interpretation that was positive for their HIV-1 Western blot. Of the HIV-2 cases that were reported to CDC, 60% of those who turned out to have HIV-2 had a HIV-1 Western blot that was interpreted as positive for HIV-1. So these people ended up getting misdiagnosed, and very often their HIV-2 only got diagnosed after they were getting sicker and deteriorating immunologically despite having a negative viral load. And of course, most of these people were not on therapy because they did not have a viral load that indicated a high viral load for HIV-1. So as a result of all these findings, CDC and APHL have proposed a new HIV diagnostic algorithm, which is already listed as one of the diagnostic alternatives in the algorithms of the Clinical Laboratory Standards Institute, CLSI. And I think most of you are now familiar with this. We'll be recommending that screening be initiated with a fourth generation HIV-1, HIV-2 antigen antibody assay. If the person is positive on that 4th generation assay, they would then get an antibody test that differentiates HIV-1 from HIV-2 antibody. This would be done instead of the HIV-1 Western blot. If the second assay is positive for HIV-1 antibodies or for HIV-2 antibodies, a person would be considered to have HIV infection and referred in for therapy. If this antibody test is negative, the specimen would go on for nucleic acid testing in order to detect the people with acute HIV infection. One consideration, though, is that with this antibody differentiation assay, because of cross-reactivity, there are a small proportion of people who will be undifferentiated. In other words, positive for both HIV-1 antibodies and HIV-2 antibodies. Most of our evidence that we've accumulated indicates that these people have HIV-1 infection, but they will probably be reported out as HIV antibodies undifferentiated, and if it's clinically indicated, they may need to have additional testing for HIV-2 in order to determine whether HIV-2 infection is present. Of course, the currently FDA-approved assay to differentiate HIV-1 from HIV-2 is the multi-spot, which is a rapid HIV test that can be done in about 15 minutes, which means that it really will reduce the turnaround time for the people who do have HIV infection and have antibodies that are present. This test has 2 spots that indicate HIV-1. One's a recombinant protein, the other is a synthetic peptide. And in order for it to be considered positive as a supplemental test, both of those spots have to be present in the laboratory. And then it just has a single spot for HIV-2 and as well as an internal control. In terms of nucleic acid tests for diagnosis, at the current time, only the Aptima HIV-1 qualitative RNA assay is FDA approved for HIV diagnosis, so that viral load tests, even though much more widely available, are not approved for HIV diagnosis, although clinicians can order viral load tests in order to get prognostic information and potentially shorten the turnaround time, but labs are not able to use them as a reflex test as part of the algorithm. Only the qualitative RNA assay is FDA approved for that diagnosis. And so just for information of people who weren't aware, APHL and CDC have a demonstration project and have contracted with 2 laboratories, the New York State Lab and the Florida State Lab, as reference laboratories that will perform Aptima for specimens from other public health laboratories because the Aptima is not as widely available as the other tests in the algorithm. In terms of this new algorithm, there have been a couple of experiences published. This one was from Massachusetts in their first 12 months of implementation of the algorithm. They tested nearly 8,000 specimens, of which 258 were positive for HIV-1 antibodies. One of them, in fact, was positive for HIV-2 antibodies. And with this new algorithm, they detected 8 acute HIV infections. They sent those specimens to CDC, where we ran the 3rd generation assay on them, as well as Western blot. 6 of those specimens were negative on the 3rd generation EIA, and they were Western blot negative, so those infections would have been missed by the previous algorithm. In 2 cases, the EIA was reactive and the Western blot was indeterminate, so they would have been detected if they had come back for retesting on the basis of the indeterminate Western blot. I do want to mention that APHL has developed suggested reporting language for the new laboratory diagnostic testing algorithm. Unfortunately, it has a very long URL that you see there. I found these basically by just Googling APHL HIV reporting language, and it was the first hit on top. But this gives advice to laboratories how to report the results of each one of these tests and each of these combinations. So it will be of some assistance, I think, for people in interpreting the results of the new HIV diagnostic algorithm. New York State has also developed reporting language, which is available on the New York AIDS Institute website for suggestions on how to report both to laboratories as well as for reporting to surveillance programs. The last thing I wanted to talk about was a thing that's come up before about using rapid HIV testing algorithms to improve the accuracy of HIV testing, because this, I think, has become sort of a chronic question. I do want to point out that especially now with the determined combo and with the differences in the assay's ability to detect early infection, it really complicates the issue of choosing tests for using in a rapid testing algorithm. This study was done actually back in 2010, and Kevin Delaney presented it at the Retrovirus Conference in 2011, although I don't believe that it's been published yet. But in this algorithm study, the intervention was that clients who had a preliminary positive rapid test had blood drawn for standard confirmatory testing off-site. At that time it was the Western blot. And then they had up to 2 additional rapid blood tests. If the person had 2 positive rapid HIV test results, they received a same-day referral for HIV care. This particular study with the intervention in the rapid test algorithm was done at 4 sites in Los Angeles and 5 in San Francisco. For comparison, people received essentially the conventional treatment. If they had a preliminary positive rapid test, they had blood drawn for standard confirmatory testing and an appointment scheduled, usually for 7 days later, to get their confirmatory test results. And if the confirmatory test was positive, they then received a referral for care. And this was in 12 sites in Los Angeles and 11 sites in San Francisco. The results, basically, at the intervention sites, there were 37 tests that were false positive, about 15%. At the comparison sites, there were about 14% of the tests were false positive. Of those at the intervention sites with the algorithm, 213 were confirmed positive and 213 were positive on multiple rapid tests in the rapid test algorithm. All of the individuals received their test results at the intervention sites, but at the comparison sites, only 430 or 47% of the individuals received their confirmed positive test results. I do want to point out that in the rapid test algorithm site, there was one client who tested positive on the first test, negative on the second test, and then positive on the third test in order to get his algorithm results. So the algorithm, if you use just 2 tests, is not always going to be perfect. But the thing I do want to point out is that the crucial issue here is whether people get into care or not, and that was in fact the outcome of the study. And what they did in both sites was look at surveillance data to see whether people received a CD4 count and a viral load test result. And so of the 213 who were positive on the multiple rapid tests, they received an immediate referral and are considered to be the intervention group. The 430 who received their results are the only ones who received the referral in the comparison site group. So that looking at whether they got a CD4 count and a viral load within 3 months, there were about 1,004 HIV-infected persons who were eligible for linkage, but some of them tested anonymously, and so they couldn't do follow-up on them. Some of them were outside of the jurisdiction, so that there were 755 individuals who were available for the engagement and care analysis, 179 of them from the intervention sites. And these are the sort of interesting findings, I think. If you look at the sort of bright green line, these are the intervention individuals from the rapid HIV testing algorithm who received their test results and a referral for care on the same day. And as you see, about 55% of them ended up making their care visit within 2 months. In the light brown line, you see the people in the comparison group who came back for their HIV test results and received a referral. And about the same percentage of them ended up getting into care within 3 months of their diagnosis and getting a CD4 count and viral load. But what I think is really interesting in this particular study is that this group of people here, which represents about 45% of the individuals who had a positive rapid test and never came back for their confirmatory test results, did end up making their first care visit within 90 days of their positive rapid test result. And so what this indicates is that they didn't come back to get the confirmatory test results. They just went right to a care setting on the basis of positive rapid HIV test result without coming back to the testing site for their confirmatory test results. And so overall, the positive predictive value of the algorithm was 100% compared to only 85% for a single rapid test. In terms of looking at engagement in care, 67% of the clients who received a referral, whether that was after the 2 rapid tests or after the confirmatory test result, ended up in care. But 50% of the clients who never came back for the confirmatory test results or never received a referral ended up engaging in care on the basis of just a single reactive rapid test result. And so I think that the conclusion that I take from this whole study is that referral to care after a reactive rapid test is essential whether or not you conduct a second rapid HIV test result. And just to reiterate, CDC and HRSA finally in February of 2013 came to an agreement and issued guidance to programs to clarify questions and concerns about referring people to Ryan-White testing programs after a single reactive rapid HIV test result. And that letter stated specifically that there is no legislative requirement for a confirmed HIV diagnosis prior to linkage to Ryan-White HIV/AIDS program funded care, nor is there a specific program requirement related to the use of the Western blot. And this letter stated in addition that having positive results from only one HIV antibody test should not be a barrier to linkage to care to a Ryan-White funded clinic or other HIV care provider program. So this was authorization to refer people and establish linkage programs even before confirmatory test results were back. So therefore, you do have three options for referral. Obviously, what we're doing now in many cases is referring only after a positive supplemental test, recognizing that some patients won't come back and will seek care even without getting their second test result. We could conduct the algorithm and refer to care after two reactive rapid tests. Some programs have attempted to do that and have found that actually it's logistically difficult to maintain inventory and maintain quality control on two rapid tests. And if you're only using two tests, recognize that positive on one and negative on the second still requires follow-up because a small percentage of those people will turn out to be HIV positive. And then the third option is to refer people to care after one reactive rapid HIV test result, recognizing that a small percentage of those patients will be HIV negative. It will be a false positive rapid HIV test result. But you do need to arrange with the Ryan-White program's specific intake for the people who need additional testing. That has been a request of the HRSA programs that you let people know when you're referring individuals who do need to have their confirmatory test done at the Ryan-White HIV/AIDS program. So for additional information on the things I've talked about today, there were actually two supplements to the Journal of Clinical Virology, one that was published in 2011, the other one just published in December 2013. These are both open access, and so all of the journal articles related to the HIV tests that I've talked about, related to the timing and related to comparisons with the new algorithm, are all available for free download from journalofclinicalvirology.com, so that if you'd like more information or to look at any of the specific papers that I referenced today, you can get them pretty easily and for free by just downloading from this particular website. So I think that's all that I have to talk about today, and hopefully there will potentially be some questions that people have that they've brought up overall, and so I'll be quiet now and see what has come up with other individuals during the presentation.
Thank you so much, Dr. Branson. We're going to open up the lines. We're going to invite you, I should say, to unmute your lines and ask questions now. To do so, you'll press *7 on your phone. It does look like we have a question asking whether or not there's been an update about a rapid viral load test.
What I can tell you is that there have been several rapid viral load tests that have been developed. There is one that is in clinical trials in the United States for consideration for FDA approval. I don't have an update on how far along those clinical trials are. It is designed to be a fingerstick viral load test that takes between 30 and 45 minutes, but I don't yet have information on its performance or on how soon it is likely to become available. One thing I did want to mention while other people are waiting for their questions is that if programs are using or begin using the determined combo test, our recommendation is going to be that specimens with a reactive rapid test, whether it's the determined combo or any other test, go through the new algorithm. In other words, get tested with a 4th generation laboratory immunoassay, and if that 4th generation assay is negative, they would not need to undergo further testing, so that the laboratory tests are more sensitive than all of the available rapid tests, which is different than it was in the past. And we are not recommending, we will not be recommending that all reactive rapid tests go through a complete sequence of confirmatory testing.
Bernie, do you have a sense on when that might be actualized formally in guidance, or is that going to be part of the new algorithm guidance?
It is part of the new algorithm guidance. That has been now cleared by the CDC Office of the Associate Director for Science, but it is out for what is required peer review. After that peer review, it comes back to CDC. If there are any changes that have to be made, it will be through clearance again, but then it will be issued. And so finally, I think we're very close to issuing it. And that advice with respect to the confirmation of rapid tests and the determined combo will be in the new recommendation.
Terrific. And I won't even think to ask you for a time frame for that.
Thank you.
One of the questions that we get quite a bit in NASTAD relates to what should we be thinking about in non-clinical community-based settings around rapid testing or transitioning to serum-based or conventional testing. And I'm wondering if you could comment on that from the perspective of performance, but also in terms of yield of programming.
It's a difficult question, Lisa, that you asked, because obviously it's important that people have access to testing and access to their test results. And if the programs are only able to conduct oral fluid tests, potentially doing that is better than doing nothing. I know that a lot of programs have begun moving the way I showed you the example from Texas, and I think Massachusetts is doing the same thing, encouraging people to either do finger stick testing or preferably to perform phlebotomy in order to send them for the most sensitive kinds of tests. That obviously would be desirable as long as we can have systems in place to make sure that people get their test results. And I think we potentially have to start rethinking how we deliver test results. A lot of the problems that we experienced in the 90s with lousy return for test results was in the era before cell phones, the era when it was much more difficult for people for us to reach people or for us to get follow-up with people, where now there are many other ways that we can get in touch with someone and ask them to come back into the clinic, whether that's a test message or come back to the test site, I should say. So that I think it would be desirable if programs were able to conduct phlebotomy as long as they could make sure to get the test results back to those individuals. I think there will continue to be a role for rapid tests. And certainly I think that as the rapid tests improve, and it looks like that the determined combo will likely offer an advantage over the other tests, we ought to be trying to use the most sensitive tests that we can in the populations that are at highest risk, and I presume that those are the programs, those are the people that our non-clinical testing programs serve. Does that answer your question, Lisa?
Yes, thank you. We have a couple of questions coming in on the chat. Bernie, I'm not sure that you can see those, so I will...
Yeah, I'm seeing them now. One I don't quite understand, which is, are there ongoing studies with rapid discordant tests? Does that mean with combinations of rapid HIV tests at the point of care? If someone could clarify what that question means. In the meantime, I'll go on to the other one. It said, looking at serum-based testing, what does that mean for home testing, which is rapid HIV testing? And again, I think that the home test is something that if it improves or brings testing to people who would otherwise not be tested, I think that it is a valuable modality. On the other hand, as I pointed out, the home test has a much longer interval between the time of infection to the time that it picks up confirmatory before it picks up infection, and so it's got a much longer window period in that circumstance. And of course, in the clinical trial, the sensitivity of the home test in the hands of home users was only 92% for people with established infection, and so its sensitivity, even for people who were antibody positive, not in the window period, was lower than it is in the hands of professional users. And so I think that there is some reason for caution in terms of home testing, which is oral fluid-based rapid testing. the clarification, I guess, came through, which was looking at the point-of-care rapid test and lab-based confirmatory testing. And I think that we will continue evaluating the different alternatives for that. The determined combo, for example, has not yet been in widespread use, and so we will be conducting follow-up studies on that. But at the current time, I think that we will be encouraging programs to submit blood specimens for confirmatory testing in order to allow them to go through both the fourth generation tests, the HIV-1, HIV-2 antibody test, and if necessary, the nucleic acid test. The question from Heather in terms of asking about selecting the rapid testing technology that they're using, how much weight should they place on the HIV-1-2 combination versus just the HIV-1 test. First of all, I think that almost all the tests are HIV-1, HIV-2 tests that are available. The INSTI test I know is CLIA waived, and they have submitted their HIV-2 application to FDA, so it does contain the antigen for detecting HIV-2. The Unigol test is now approved for HIV-2, and so there may be one laboratory test that has an FDA indication for only HIV-1. Otherwise, all the tests that I'm aware of are actually HIV-1, HIV-2 tests, and so they will detect both of them. As I mentioned, HIV-2 is still somewhat uncommon in the country as far as we know, but there are probably more cases than we've been able to detect simply because of the cross-reactivity with HIV-1 on the Western blot. So I'm hoping, Heather, that answers your question about the HIV-1 versus HIV-2. The next question has to do with labs that require a separate tube of blood in order to run the nucleic acid test. And is a separate tube of blood necessary? And the answer is that you have to do what your lab requires in those situations. There is some concern, and it depends on how the laboratory conducts their testing for antibody about whether or not there might be the possibility for contamination of a specimen, which is why they require a separate tube of blood for running the nucleic acid test. In addition, the fourth generation tests have specimen requirements that require that the specimen get to the laboratory in a shorter period of time. With the Bio-Rad test, it's within 48 hours. With the Abbott test, it's within 72 hours. So the specimen transport is a bigger issue. And that is the concern with doing the nucleic acid testing, which is there is a time limit between when the specimen is collected and when the specimen has to be run in order to get an accurate RNA test result. And so a lot of that has to do with basically the laboratory's testing mechanisms and the specimen transport requirements, so that there are some laboratories that will conduct the nucleic acid test on the same tube of blood because it can be run on serum or in plasma. There are others that require a separate tube of blood, and it may be necessary, again, depending on the lab's specific procedures, the way they do it.
Bernie, you mentioned earlier about delivery of results. Oddly enough, I've just gotten a text message on my phone asking if there are any guidance from the CDC about alternative methods for delivering results that don't rely on the face-to-face that you can point us to.
Actually, in the last recommendations for providing results, I think it said they needed to be provided by personal contact. Which I think may have been interpreted as face-to-face, but it's not an absolute requirement to provide results face-to-face. There are a number of programs that have been providing HIV test results by telephone for years, and I know that there is program guidance that is on the way that's coming out that will more explicitly address the issues of how to provide people with test results. But I think the crucial issue is that you have to do what it takes in order to get test results to individuals. And I think, again, a lot of STD test results, people are being invited either to get them by telephone or they're being invited to come back to the clinic for positive results either by a telephone message or a text message. And so I think that we need to take advantage of those mechanisms in order to contact people, and then individuals' programs have to decide whether or not they will provide positive test results by telephone. There are a number of programs, testing programs, that have been doing that for years and have not encountered any difficulties with it, and so it's, I think, a program by program determination.
Okay. Thank you. One of the other questions that we get quite a bit relates to this issue of third-party reimbursement, and particularly for conventional laboratory-based testing where there's a public health lab that is providing the testing, and that public health lab does not have the capability or capacity to do third-party billing. Do you have any sense of how that is understood or viewed at CDC, or what we should be thinking about?
I think the issue is perhaps less how it's viewed at CDC than how it's viewed in Congress. CDC obviously has to deal with whatever is appropriated, and there has been considerable interest in Congress to make sure that CDC and public health is not paying for things that are otherwise reimbursable. And so I think that we will see increasing emphasis being placed on attempting to get reimbursement for things for which people have coverage, and especially now with expanded coverage under the Affordable Care Act, there will be more people in more circumstances who have coverage, because the task force recommends HIV testing for people age 15 to 65, and anything with a grade A recommendation from the task force is covered under the Affordable Care Act. I think that people should anticipate that there is going to be an increasing movement toward attempting to seek reimbursement for testing, and whether that's conventional testing in the laboratory or rapid testing in other circumstances. And so I think that it might be a good idea to get ready in order to move in the direction of being able to bill and to seek reimbursement when people have coverage for these tests.
Thanks. That's very helpful.
And Jessica had just put a chat question basically wanting me to confirm that rapid tests that are positive should be put through the algorithm, tested with the 4th generation assay, and if the 4th generation is negative, you don't go on to step 2 of the algorithm. So that if the 4th gen is positive, you would continue with the algorithm in order to determine whether it's antibody that's present or whether it would need a nucleic acid test. The reason I'm mentioning this is that the current, or rather the old recommendation dating back to about 2006, was that if a rapid test was reactive and you performed an EIA on the specimen and the EIA was negative, you should still go on to a Western blot if the intermediate EIA was negative. The new recommendation, because the 4th generation tests are more sensitive, is that if the 4th gen is negative, you would not go on to the subsequent tests in the algorithm. You don't need to do additional confirmatory testing.
Are there additional questions for Dr. Branson? Do you have any questions for us, Bernie?
No, I don't think so. I saw a lot of familiar names on the list from people who have sort of been doing this. And I guess I do have a question, and Lisa, you may be familiar with it, but sort of what is the thinking in state health departments now about the idea of doing more phlebotomy in order to do earlier detection of people with HIV infections?
I think our sense within NASDAD, and I invite others to comment on this, is that in general there's a recognition that it's useful and important to do. I think we get caught up in the operational concerns of how do we do this in a way which makes sense and is feasible in the context of the individual programs that we support and that we work with. I mean, it feels very much to me like it did when we were transitioning to rapid testing and then oral testing before that. It was, let's deal with the policy issues. It's a good thing. Now, how do we do it?
This is Ralph Wilmot at the Arkansas Department of Health. And those of us that did STD work, syphilis work in years gone by, all were trained to do phlebotomy in the field. And this just is a clear indicator that we need to get our staff geared back up to do that work and be able to draw blood to do the best testing that's available.
I'm actually sort of glad to hear you say that. On the one hand, I understand, Lisa, what you're saying, which is that it's desirable but in some cases impractical in order to do it. But I think that the idea that we ought to be offering, especially our highest risk persons, the best testing possible, I think is going to become really, really important. I mean, I think that, in healthcare settings, clearly people have access to these better tests and they ought to be using them in those circumstances. The real thing, though, is now that we're down to about, only 16% or so of people unaware of their HIV infection status, there are going to be a larger and larger proportion of infected people who do have acute HIV infection. And the only way we're going to, I think, get this under control is if we do a better job of detecting them.
Well, I didn't mean to suggest that the thinking is that it's impractical. It's thinking about how to go about doing it and not dismissing out of hand that it can't be done because it's a community-based setting. I remember the days dragging around the centrifuge to bars. I know it's practical. I think others are remembering that too. And to Ralph's point, is we're transitioning a workforce in many ways to go back in some ways to the way that we used to provide field services. And we're transitioning a workforce that doesn't necessarily have those skills and the experience that I'm describing. But I appreciate the point about the perceptions of it being impractical.
Hi, this is Barry in Massachusetts, and I just wanted to make a comment about this topic. This is where partnerships between health centers or healthcare facilities and non-healthcare facilities is really key.
I think I agree with that. We really have to get the healthcare facilities involved, in particular, and get their assistance in sort of working in this direction.
Hi, this is Marlene Lalota in Florida. We feel really strongly about this issue here, and so much so that we've used quite a bit of resources from the prevention grant, probably upwards of $10,000 at this point, to provide phlebotomy training for communities. We started in Broward County, Fort Lauderdale, and then other areas have done similar. And we've trained, I don't even know what the number is, but hundreds of people in how to do phlebotomy. We also had to deal with the insurance issues. That's what we kept hearing was the barrier from our community-based organizations. They can't afford the insurance. So when we found a couple of smaller CBOs that actually did find, that they were able to keep their insurance and the annual increase in their premium was minimal, maybe a couple of $100s, we use those people as our spokespersons to help convince other CBOs that really isn't a barrier. We've done similar work around, biohazardous waste and, buying, needles and tubes. And, we've just tackled sort of each issue one at a time. And as a result, we've really, really decreased the proportion of our testing that has oral anywhere in the algorithm. We still have it because there are some providers that's really, all that they can do, but we're whittling away at it, little by little.
Great. Another question came through in the chat, and this one I think was from Hope Cassidy Stewart, asking about whether there is still a role for the Western blot in the laboratory algorithm, mentioning that they're having trouble convincing many laboratorians to move away from the Western blot. As some of you have seen my presentation before, I have a slide in it with a Western blot support group for laboratorians like that, because of the difficulty of sort of letting go. The Western blot is not a bad test, but it only picks up IgG antibodies. It does misclassify HIV-2 infections. There are more indeterminate results in it. And it is basically a longer turnaround time test. And so if you wait to do a nucleic acid test after a Western blot is negative or indeterminate, what you're doing is delaying people. Hope's comment was this doesn't seem cost effective, and I think that we agree that the difficulty with the Western blot is a more expensive test. There are rare circumstances where you have a diagnostic dilemma. You can't figure out what's going on with somebody, and so potentially doing the Western blot and figuring out exactly which bands are present might be helpful. But in terms of doing the Western blot, and then if the Western blot is negative or indeterminate, going on and doing the nucleic acid test, that's a very expensive and it's a very time-consuming approach. And so the thing that had delayed laboratories for a while was that the differentiation assay, the multi-spot test, did not have a specific FDA indication for use as a supplemental test. And the Western Blot is called a supplemental test. In March of 2013, the multi-spot received that indication, and so if you have difficulty with laboratories, I think it's useful to tell them that this is a faster test, it is an easier test to perform, and it has the same specific FDA indication as a supplemental test, so that it makes a lot more sense for people to use it. And Marlene, I didn't mean to ignore your comment. I really appreciate the experience that Florida has had in moving people along, and I think that most people will experience what you have, is that we have to continue to maintain more than one approach for different populations.
Hey there, this is Jenny in Texas, and through our transition, one thing that we keep reminding our administrators at our programs, specifically our targeted testing sites, is getting through change and what they are used to. And we've had such change in the the HIV arena, to where those of us who were, like Lisa said, carrying around our toolbox with our phlebotomy materials, we remember the only option we had was to draw blood. But I used Dr. Steckler's survey that they did in the Washington area, where they showed, they talked to patients about, here's the sensitivity, here's the specificity, here's when you will know whether or not when you were infected. Now, which do you trust more, and which would you prefer? Well, an oral swab or a blood draw?
Actually, Jenny, that particular study was when people had gone through all of the tests. Mm-hmm. They had a blood draw, they had a finger stick, they had a oral swab, and they asked people what specimen collection method they preferred, and most preferred was oral fluid, least preferred was phlebotomy. They asked people what test result they trusted, and most trusted was phlebotomy, least trusted was oral fluid. And as they then asked people, if you could have only one test today, what would it be? And they wanted a nucleic acid test. And so
right,
I think
which would be a blood draw. And, yeah. And so that's one thing that we remind people, because they keep thinking, oh my gosh, we're going to not be able to test anybody. It's like, well, that's what you think.
I think it is worth asking people, because I think once they recognize that there's a difference in accuracy, people react differently, and I think that's the point that you're trying to make, right? Once you
exactly. There's so much, people are so caught up in, well, this is the way we've been marketing it, this is the way we've been doing it all along. Well, think about remarketing it, reframing it with your patients. And I totally agree with Barry, the most people that are going to be testing are the healthcare providers.
Right.
And we've been fortunate to get most of our care providers to do, blood-based testing. But the few that are still doing rapid testing, it's transitioning them out of it.
Great. Justin has sent a question through chat asking, will NAT replace PCR? And I'm really glad that you asked that question, because I don't want to confuse folks. NAT, or nucleic acid test, is a generic name for testing for HIV RNA or HIV DNA. PCR is one method to do NAT. So PCR stands for polymerase chain reaction, which is a way to do an RNA test. There's also a PCR for a DNA test. There are a couple of others called branch DNA. Another one is called TMA, transcription-mediated amplification. And so PCR is one type of NAT. But there are several different types of NAT, and NAT is sort of an overall generic term for testing for HIV nucleic acids like RNA or DNA.
Any additional questions from the callers? I don't see any additional questions in the chat. Going once, going twice. Jillian, do you have wrap-up?
I think that's it for us today. I know we're ending a little bit early, but thank you so much, Dr. Branson, for spending the afternoon with us today.
You're welcome.
Everybody, thank you, and please refer back to our website. I would say Friday or Monday at the latest, we should have both the recording and the slides available. Lisa, anything from you? All right, well, with that, thank you, everybody, and have a great afternoon.
Great, thank you.
Thank you. Please stand by.